Okay, this skill is going to be a trauma assessment. So we are responding to an unresponsive patient laying beneath a tree at the local park. As we arrive on scene, we ensure scene safety and that we are wearing the appropriate BSI. As we begin to approach the patient, we're going to go ahead and start doing our scene size up. So we're going to look for any witnesses that happen to see what had happened. We see none. We're looking for any environmental hazards. None are present. Looking for the number of patients, which is one unresponsive patient laying underneath the tree. As far as the mechanism of injury, none is obvious, so we're going to assume trauma. As far as any additional resource needs that we may require, at this point we do not need any. And then as far as a need for C-spine, based on the unknown mechanism of injury, we will take C-spine as appropriate. So as I get to the patient, I call out to the patient, "Hey buddy, can you hear me?" There's no response. Gonna go ahead and tap and shout, "Hey buddy, no response." Gonna go ahead and look and listen and feel for signs of life. I do have a good carotid pulse, and there is good rise and fall of the chest. So at this point, I do have a completely unresponsive patient. In doing a quick scan of the body, I do not see any obvious life threats. So we will go ahead and stay in play with a full assessment on this patient. No additional resource needs are necessary. And again, he is completely unresponsive. We can also do painful stimuli to see if he becomes responsive to pain, but there is no response to painful stimuli. So at this point, I'm going to go ahead and tell my partner to hold manual stabilization of the patient's head. I'm going to go ahead and get a cervical collar so we can place it on the patient as appropriate. So once I've got that, I will set it to the side so I can assess the head and neck prior to application of the cervical collar. So as I begin my head-to-toe assessment, I'm going to be looking for DCAT BTLS, which stands for deformities, contusions, abrasions, punctures or penetrations, any burns, tenderness, trauma, lacerations, or swelling throughout the entire patient. And then when I'm palpating, I'm going to be palpating for any tenderness, instability, or crepitus. So with my gloved hands, I'm going to go ahead and apply gentle pressure around the head and the back of the head, pulling my gloved hands back to see if there is any blood on my hands from the back of the patient's skull, making sure that there are no spongy depressions to the skull. I want to check the ears on both sides to make sure that there's no drainage of fluid, either clear cerebral spinal fluid or any blood coming from the ears. I want to check for bruising behind the ears or Battle's signs that are going to be an indicator of any head trauma. Coming to the front of the head, I'm going to palpate the forehead, I'm going to palpate the cheekbones, I'm going to take a look inside the nose and mouth to make sure that there's no obstructions, no oral trauma, no CSF coming from the patient's nose. I also want to check the eyes for pupillary response. So I'm going to open up the eye, check it with my pen light to make sure that both pupils are equal and reactive to light as appropriate. I'm then going to come down to the neck. I'm going to palpate the cervical spine for any step off or dislodging of any of the cervical vertebrae. Coming to the front of the neck, I want to look for any subcutaneous emphysema around the neck. I want to look for any tracheal deviation or shift. I want to look for a stoma, any jugular vein distension, or any medical alert tags. After I clear the neck, I want to go ahead and press down on the clavicular structure one time for stability. Once that's set, I'm going to come down to the center of the chest, to the sternum. I'm going to press down on the sternum one time to check stability. Once that's clear, I'm going to go ahead and apply my cervical collar. So I will measure at the prominent location at the base of the neck going up to the patient's jaw. I'm going to take those number of fingers, apply it over to my cervical collar, lock it in place, and again with my partner still holding C-spine, I'm going to place the cervical collar behind the patient's neck and head, and then make sure that I have this completely snug and sized appropriately for this patient. My partner will continue to hold C-spine. As we continue our head-to-toe assessment, we're going to go ahead and palpate the side walls of the chest. With the chest, I want to look for any subcutaneous emphysema, any paradoxical motion that's going to identify a flail chest, or any other obvious injuries that I see. After I visualize that, I'm going to go ahead and auscultate the patient's chest, both upper and lower lobes, and then the mid-axillary lines to make sure that I've got good breath sounds with the patient. As I continue down, I'm going to go ahead and come down to the abdomen. I'm going to palpate all four quadrants of the abdomen inside out. I am palpating for any distension, rigidity, or pulsating masses to the abdomen. As I continue down to the pelvic region, I'm going to go ahead and press down one time on both sides of the pelvis to ensure stability. I'm going to check for any priapism or uncontrolled erection. I'm going to look for any loss of bladder or bowel function. I'm also going to check for any possibility of priapism or an uncontrolled erection on the patient. If there is bleeding present, I want to make sure I completely expose the area to determine if it's internal or external bleeding, and then control it as appropriate. Coming down to the long bones, to the legs, I want to use offset pressure above and below each joint to check for tenderness, instability, and crepitus for both legs. Once I have cleared the legs, I want to check CMS. So I'm going to check pedal pulses both at the same time. And since my patient is unresponsive, I can't do a pinch test to check sensory response. So I will take my pen light and do the Babinski method on the bottoms of both feet to get a curling of the toes on that. Once that's set, I'm going to go ahead and come up to the upper extremities and again do my offset pressure on the long bones of both arms. And I'm going to check radial pulses on both arms at the same time to make sure that they are both equal. Since my patient again is unresponsive, I am not going to be able to do any sensory or motor function tests on the patient's arms. Once I have completed my assessment on the front of the patient, we are going to roll the patient, do a log roll of the patient toward me on my partner's count, and then we are going to prepare the patient to be placed onto the backboard. So I want to make sure that my straps are all clear and ready for use for this patient. Again, this is going to be on the head's count. So on my partner's count, we are going to roll the patient toward me. 1, 2, 3, roll. With the patient rolled toward me, I want to go ahead and visualize the entire posterior of the body, again looking for any bowel or bladder dysfunction. I want to walk the spine, checking that I don't have any step off or any other obvious injuries that I can see now that the patient is rolled. I then am going to go ahead and bring my backboard over, and on my partner's count, we are going to replace the patient back onto the backboard. 1, 2, 3. And then adjust the patient as necessary onto the backboard. Once we have the patient centered on the backboard, we are going to go ahead and strap them onto the backboard as appropriate, making sure that my color-coded straps are strapped in appropriately. So we want to make sure we go over the shoulder. Since our patient is unresponsive, we also want to secure the arms inside the straps. Again, with the other upper torso strap, we're going to go ahead and go over the shoulder, and making sure that the arms are secured inside. Since this is a pediatric patient and a long spine board, we want to go ahead and wrap the feet to make sure that the patient does not slide one way or the other on the backboard during transport. Once I have the patient secured to the backboard, we're going to go ahead and check CMS again as appropriate. At this point, we can go ahead and apply the head blocks to the sides of the patient's head. I will have my partner remove their left hand so I can place this along the side of the patient's head, and then have my partner remove his right hand so I can place this. We'll go ahead and place the strap over the forehead, going down to the 2 head blocks. Once that is set, my patient is now ready to be placed into the ambulance. Once the patient's been placed into the ambulance, I will go ahead and get a complete set of vital signs, pulse, respirations, blood pressure, oxygen saturation as appropriate, skin temperatures, and again with our pupillary response. If my patient was responsive, I would be able to ask them the interview questions as appropriate, my sample, signs and symptoms, any allergies, any medications, any pertinent past history, medically speaking, the last oral intake, what and when, and the events leading up to the incident. If he had any complaints of pain, I would also ask them the OPQRST questions. The onset of the pain, any provocation, makes the pain better or worse, the quality of the pain, whether it's sharp, dull, etc., severity of the pain, on a scale of 1 to 10, 10 being the worst, radiation, if the pain is moving anywhere, and the time, how long this has been going on. During transport, I would go ahead and reassess this patient every 5 minutes since this is an unresponsive pediatric patient And I would also apply oxygen to this patient since it is an unresponsive pediatric at 10 liters per minute via non-rebreather mask. Again, reassessing the patient every 5 minutes during transport.